بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. شرفنا في وحدة المناعة الإكلينيكية في قسم البطنة ومدرسة المناعة الإكلينيكية إن احنا نرحب بضيفنا العزيز الغالي الدكتور سمير شوقي. ودي إن شاء الله من المرات بفضل الله بنبدأ فيها تعاون مع التخصصات الأخرى، خصوصا تخصص الأوفثالمولوجي من الحاجات اللي بتواجهنا فيه مشاكل كتيرة. فدكتور سمير بصراحة أنا كان ما سمعته في المؤتمر، ربنا يكرمه ما شاء الله، كان أسلوبه شيق وأمتعنا وحتى أثار أسئلة كتيرة، فربنا يكرمه لما دعيناه ما تأخرش. دكتور سمير فيلو اكزامينر في الرويال كوليدج اوف فيزيشنز اند سيرجنز اوف جلاسكو، وهو محاضر متميز وعلى علم ان شاء الله. فنديله بقى الفرصه ونشكره اولا المستجاب للدعوه، ونديله الفرصه بقى انه يمتعنا ان شاء الله. وهستاذن حضراتكم الاسئله هتكون بعد المحاضره عشان احنا السيكونس بتاع التسجيل، فاللي عنده سؤال يكتبه معاه وان شاء الله هنغلس على الدكتور سمير باسئلتنا ان شاء الله. اتفضل يا فندم.
السلام عليكم ورحمة الله. شكرا جزيلا دكتور أحمد لحضرتك على الدعوة الكريمة، والحقيقة مقدمة يعني جميلة لا أستحقها والله، ربنا يبارك في عمرك. والشرف والسعادة ليا أنا بوجودي وسط حضراتكم إن شاء الله، وأتمنى السيشن تكون انتر اكتف، وطبعا أكيد تحت أمر حضراتكم في أي أسئلة. وبرحب بيكم دايما لأنه التعاون بيننا وبين زملائنا في الروماتولوجي تعاون مستمر لمصلحة المريض طبعا إن شاء الله. First of all, I would like to thank Dr. Ahmed, of course, for the kind invitation. And today we have an important and interesting topic. So when we deal with our colleagues from the rheumatology, they usually think of uveitis. And in fact, uveitis is not the whole manifestation of rheumatic diseases. We have presentations other than uveitis. As we all know, ocular manifestations occur in many rheumatic diseases, and there should be a good collaboration between rheumatologist and ophthalmologist in order to help the patient overcome the comorbidity and to reach a definitive diagnosis, and to help the patient. Sometimes from the eye, you can diagnose very serious and lethal diseases. So the communication and the collaboration between rheumatologists and ophthalmologists is mandatory. As we all know, rheumatic diseases have very much ocular manifestations and can affect several parts of the eye, starting from the dry eye and affection of the eyelids, affection of the episclera, the sclera, the cornea, the uvea, the retinal diseases, and even the optic nerves. And of course, uveitis, which is common. Uveitis could be in the form of anterior uveitis, where inflammation mostly affects the ciliary body and the iris. We call it anterior uveitis. It can be in the form of intermediate uveitis, where inflammation is mostly affecting the peripheral retina and the vitreous, or it can be posterior uveitis, where inflammation affects mainly the choroid and the retina. And in rare occasions, it is a panuveitis, where inflammation affects the whole parts of the uvea. Again, we have to collaborate with each other in order to help the patient. The layout of my talk today, I will talk about 3 diseases that are not associated with uveitis mainly. They are associated with other conditions other than uveitis. I will talk about hydroxychloroquine toxicity, which is very important in our practice. And I will talk about 3 important causes of uveitis in our practice. The first disease entity today is rheumatoid arthritis. As we all know, the ocular manifestations of rheumatoid arthritis include the keratoconjunctivitis sicca, which is dry eye, episcleritis, scleritis, peripheral ulcerative keratitis, and uveitis is rare, imagine, because many times when I have referrals from our rheumatology colleagues, when they refer a patient with rheumatoid arthritis, they usually think that this patient has uveitis. But in fact, when I see this patient, I put uveitis at the end of my differential. The patient is complaining. He's going to the rheumatologist and tell him, my eye aches and causing pain. And our rheumatology colleagues think of uveitis. But in fact, rheumatoid arthritis is not a common cause of uveitis. When you have a rheumatoid arthritis patient, think of dry eye first. This explains the patient's complaint. Think of scleritis and episcleritis. So this is an important message to convey today here. I will show you some of the actual cases of rheumatoid arthritis with presentations other than the uveitis. This is a 42-year-old female patient that complained of redness and pain in the left eye of 2 weeks duration. She was known to have rheumatoid arthritis and given oral steroids. On eye examination, we found this. As you can see here, we have here sclerokeratitis, which is inflammation of the sclera and the adjacent cornea. You can have here peripheral corneal melting, as you can see here. In fact, this is very dangerous situation, and this patient, if not properly treated, it can proceed to ocular perforation and the eye may be lost. You can see here the area of the corneal melting inferiorly. And sometimes we can have peripheral corneal ulcer, which is loss of the epithelium of the cornea, and this makes the cornea vulnerable to infection. And sometimes we have filamentary keratitis. And all these situations can cause severe pain and blurring of vision to the patient. The Schirmer test was 0 millimeters in 2 minutes in the right eye and 3 millimeters in the left eye. And as you all know, Schirmer test is an office procedure which we use to check the tears. And these readings are demonstrating very deficient tears, and the patient has dry eye. So our diagnosis was peripheral ulcerative keratitis, of course, and rheumatoid arthritis. This patient was admitted elsewhere and was given every form of immunosuppression you can imagine. She was given pulse steroids, infliximab, methotrexate, and oral prednisone. After 1 month, you can see here, the peripheral ulcerative keratitis was healed and the blood vessels regressed. In the last visit, there was complete healing of the keratitis and the nasal scar. And here are the pictures that show the sequences during the treatment. And you can see here the marvelous response. This was because of the right diagnosis and the good collaboration between ophthalmologists and rheumatologists. The second case is a 36-year-old female patient. She complained also of redness in the right eye for 6-month duration. She was also known to have rheumatoid arthritis. She was on Plaquenil and etanercept, and she didn't respond to Humira and was not tolerant to methotrexate. You can see here, she has similar form to the patient before, but it is milder. You can see here the scleritis, the diffuse injection of the sclera here, and the cornea, there are some peripheral corneal infiltrates. The left eye showed similar findings, the eye is angry looking with mild injection of the sclera. Extensive work was done for this patient. She was known to have rheumatoid arthritis, as we mentioned before, but anti-SSA and the anti-SSB antibodies were positive. So the patient was diagnosed as having secondary Sjogren syndrome with dry mouth, sclerokeratitis, and peripheral corneal infiltrates. The patient was treated with prednisone acetate, indomethacin, and the prednisone tablets. As you can see here, this was after 5 weeks of treatment. The eye is quieter. If you compare this case to the previous one, here the case is milder, and she responded to milder forms of treatment compared to the previous patient. The second disease entity today I will discuss is Wegener's granulomatosis. As you all know, Wegener's granulomatosis is a multi-system granulomatous inflammatory disorder with vasculitic and necrotic manifestations, and it is presumed to be of autoimmune origin. Interestingly, this disease was discovered by Friedrich Wegener, and Friedrich Wegener was a Nazist. That's why they changed the name now. Instead of Wegener's granulomatosis, they called it in 2011 granulomatosis with polyangiitis. But in fact, both terms are still used in the literature. Clinically, Wegener's have three different forms. We have the general form, which is the severe form of the disease, in fact, with widespread organ system involvement. The limited form is similar to the general one, except for affection of the kidneys. Very interestingly, we have a very limited form, which is a localized ophthalmic feature. So keep in mind that you can have ocular Wegener's granulomatosis without having systemic involvement. This is very important for us as ophthalmologists when we refer a patient to you suspecting Wegener's granulomatosis and you may not find any systemic involvement. So it is a very limited form of the disease. According to the old criteria that were put by the American College of Rheumatology in 1990, there were some simple criteria for diagnosis of Wegener, include blood cells, red blood cells in the urine, abnormal findings on the chest radiographs, oral ulcers or nasal discharge, and the granulomatous inflammation on biopsy. And the presence of two or more of these criteria was associated with a higher sensitivity and specificity for the diagnosis. But if you looked at this criteria, they didn't include the C-ANCA. And the C-ANCA is very important, and all of us as practitioners know the value of the C-ANCA in the diagnosis of Wegener's granulomatosis. It is positive in 74% of the patient, which is a high percentage. In fact, it is used in both the diagnosis of Wegener's and judging also the clinical activity. That's why the new criteria that were put recently, they included the C-ANCA, and I will not go to the details of this table. And of course, I know you know this even better than me. So how can Wegener's affect the eye? It can occur de novo without any previous manifestations of Wegener. It can occur as a result of spread from contiguous structures like the sinuses or as a part of systemic Wegener's granulomatosis. So how can Wegener's affect the eye? It can affect the orbit, which is very common, like causing orbital granuloma and proptosis. It can cause ocular vasculitis, right, like retinal vasculitis. It can cause adnexal inflammation. Adnexa here means the lacrimal glands and the tissues around the eye. And it can also affect the nasolacrimal duct, causing obstruction and tearing. If you have a look at these manifestations, there is no uveitis here, because uveitis is a rare manifestation of Wegener. It only occurs in 3% of patients. So keep in mind, you have a patient with Wegener's, think of uveitis, but don't make it the top of your differential. We have many other things that can occur with Wegener's other than the uveitis. Here I like the rule of 50. The ocular involvement occurs in 50% of patients with Wegener's, and only 50% are ANCA positive. So if you have a clinical suspicion of Wegener's and you find a negative ANCA, this doesn't exclude the diagnosis. Interestingly, necrotizing scleritis, which is scleromalacia or weakening of the sclera, occurs in 50% of patients. I will show you also a couple of cases of Wegener's granulomatosis to consolidate the knowledge. This is a 39 female patient that complained of recurrent episodes of redness and pain and swelling in the right eye of long duration. She complained of generalized pain also and fatigue, and later developed sinusitis, ear disease, and ear pain. Clinically, we can see here the eye is very angry looking, and you can see here the scleromalacia. Scleromalacia means thin sclera. You can see here, this is sclera. It shows the black coloration of the uvea underneath. This means that the sclera is thinned because of the severe inflammation. And this patient also showed uveitis, because you can see here the irregular pupil from the posterior synechia, and you can see the pigmentations over the cornea. So this patient presented to us with multiple investigations that she did elsewhere, and the obvious abnormality here was in the CT orbit, which showed mild right proptosis and she had the scleral biopsy that showed granulomatous inflammation and the multinucleated giant cells, and this biopsy is very sufficient to diagnose Wegener's granulomatosis, in addition to the clinical manifestations, of course. Furthermore, C-ANCA was positive. So if we revert back to the criteria with by the American College of Rheumatology, this patient will achieve a higher score because we have biopsy and C-ANCA positive. The second case is another female division in both eyes of 2-month duration. Review of systems was very important. In fact, as an ophthalmologist, I spend more than 15 to 20 minutes with my patient taking a very good history, because this helps me very well. I can reach up to 50 to 60% of the diagnosis from just interviewing the patient in the proper way. So please spend more time with your patient. This will help you in the diagnosis and will help you establish a good relationship with your patient, and you will convince him and he will feel that you are taking good care of him. So this patient complained of hearing loss, tinnitus, rhinitis, evidence of loss of septal cartilage. This is very important. Arthritis, genital ulcers, and some other manifestations. So when I keep these points in consideration and then saw this clinical picture, the patient presented with scleritis. It is more in the left eye, as you can see here on your right side, your right-hand side, and the scleritis is nodular in the left eye, as you can see. We ordered an extensive workup for the patient, and all were normal, to exclude rheumatoid arthritis and to exclude systemic lupus erythematosus. But the only test that came out to be positive was C-ANCA. So presence of C-ANCA in the presence of scleritis in a female patient with this septal cartilage defect, I think this is enough to diagnose the patient as having Wegener's granulomatosis. And this patient received the treatment with systemic immunosuppressive therapy. As you can see here, there was a very good response. The inflammation, the scleroderma, this is because the collagen lamellae are lost and they are showing the underlying uveal tissue. Later, this patient developed uveitis. We kept looking at the patient. As you can see here, the uveitis, you can check the anterior segment. The pupil is irregular because of the posterior synechia, and we don't have here a clear fundus view because of the vitritis. And the patient later developed severe scleromalacia. So in fact, you may see this type of lesions in your clinic as rheumatologist. You can have a look at your patient who is coming to you and you notice this black coloration. So in fact, when I see this, I think of the two entities, Wegener's granulomatosis and rheumatoid arthritis. They are the most common causes of scleromalacia, at least in our region. So please keep in mind these two diseases. The last disease in this group is systemic lupus erythematosus. In fact, systemic lupus can affect different parts of the eye. It can affect the sclera, the cornea. It can affect the retinal blood vessels, the optic nerves. And again, uveitis is not a common manifestation of SLE, because sometimes we have patients referred from our rheumatology colleagues with SLE to rule out uveitis. It can occur, but in fact, it is less than 2 to 3% of the patients. And we had written this review article. It's a very nice article that was highly cited about the ocular findings in systemic lupus erythematosus. And in this article, we highlighted the fact that uveitis is not a common manifestation of SLE. But there is an important topic that we should touch today, because patients with SLE, even if they don't have clinical manifestations related to the disease, they might have clinical manifestations related to hydroxychloroquine toxicity. I have the honor and the privilege to collaborate with many renowned rheumatologists, and they are very experts. And many patients I'm seeing with rheumatoid arthritis, with SLE are on hydroxychloroquine. So this is very important to keep an eye on these patients and to be aware of the hydroxychloroquine toxicity. Hydroxychloroquine toxicity in a large study occurred in 7.5% of patients, which is a significant proportion. We are lucky, our generation is very lucky today, because we have, as ophthalmologists at our hands, new imaging modalities that can help us in reaching the diagnosis. The hydroxychloroquine can affect the eye in several patterns. It can cause corneal deposits. It may cause posterior subcapsular cataract. Sometimes can cause ciliary body dysfunction. And just to remind you, the ciliary body is the organ in the eye which is responsible for accommodation. All these three are relatively not high risk or not causing visual dysfunction. But the most dangerous is the toxic retinopathy. As I told you, it can affect the cornea, causing corneal deposits. It takes a special pattern, which we call vortex keratopathy. Even if it happens, it can tell us that the hydroxychloroquine is toxic to the eye, but it doesn't affect vision, in fact. But the most dangerous, as I told you, is the toxic retinopathy and what we call it bull's-eye maculopathy. This is the thing that we don't like to see, in fact. If because of we reach this stage, the retinal changes may be irreversible. So our task as ophthalmologists and rheumatologists is to keep the patient away from reaching this stage. So what are the risk factors for developing toxic retinopathy from hydroxychloroquine? Any patient taking hydroxychloroquine is at risk? No. In fact, there are some risk factors. These include first, high dose. If the patient is taking more than 5 milligrams per kilogram per day, this is at high risk. Simply, if the patient, for example, is taking 400 milligrams per day, he is at higher risk. If the patient is taking hydroxychloroquine for more than 5 years, he is at risk. If the patient has a concomitant kidney disease, he is at risk. If the patient is using tamoxifen, and this is common, in fact, because cancer breast is increasingly diagnosed now. So the patients on tamoxifen are also at higher risk of developing hydroxychloroquine toxicity. Patients with already existing macular disease, like diabetic patients or patients with age-related macular degeneration, they have higher risk of developing hydroxychloroquine toxicity. So when you have your patient, please keep an eye on this. If you have any of these risk factors or a combination of these, please refer the patient to an ophthalmologist to do tests and screen the patient. So as I told you earlier, we have at our hands now some of the tools that can help us as ophthalmologists to detect early hydroxychloroquine toxicity before the patient reaches the stage on the right side, before he reaches the irreversible bull's-eye maculopathy. We have automated visual fields, optical coherence tomography, multifocal ERG, and fundus autofluorescence. And also, we published our data about hydroxychloroquine toxicity. And interestingly, we only found one patient with hydroxychloroquine toxicity among the 63 patients. And this was detected early by the use of OCT. And for our rheumatology colleagues, this OCT is the optical coherence tomography, which images the retina. And we can see here, there is an area of irregularity here in the macula with disruption of the photoreceptors. And this is the sheet that we use at our practice to detect if the patient has risks of developing toxic maculopathy or not. And I encourage our colleagues to use whatever protocol or whatever documentation just to track if the patient has a risk for developing toxic maculopathy or not. Now we will go to the third part. I will talk about 3 important disease entities that are associated with uveitis. Vogt-Koyanagi-Harada disease. This disease was named after these 3 eminent scientists. These 3 eminent scientists described the different aspects of the Vogt-Koyanagi-Harada disease. And when I have talks with my esteemed rheumatology colleagues, we are always asking, who sees the VKH patient first? In fact, the ophthalmologists see this patient first in most of the cases, and we are the ones who are making the diagnosis of VKH. So what is the VKH? VKH is an immune-mediated disease which has a predilection for melanocyte-containing tissues in the body. If we understand this concept, we will know how can the VKH affect our body and what are the manifestations. For example, in the eye, it affects the melanocyte-containing tissue, which is the uvea. That's why it causes uveitis and causes Beni-Uveitis. And it affects the melanocytes in the central nervous system, in the meninges, causing the neurologic manifestations and the meningitis-like manifestations, because these patients usually complain of headache. And they affect the melanocytes in the inner ear, causing tinnitus and decreased hearing. And lastly, it affects the skin, causing affection of the melanocytes and depigmentation of the skin, causing the vitiligo, and the depigmentation of the hair, causing the polyusis, and affecting the hair follicles, melanocytes, causing alopecia. So I think by applying this concept, you will never forget the manifestations of Vogt-Koyanagi-Harada disease. So the diagnosis of VKH or Vogt-Koyanagi-Harada disease is like the all uveitis entities. We depend on criteria. We don't have a diagnostic test, in fact. And this applies to sarcoidosis, to Behçet's disease, and the many diseases in rheumatology, I think. We rely on collection of criteria in order to reach a diagnosis. So the first thing is to exclude trauma, because Vogt-Koyanagi-Harada disease is very similar and a cousin of another disease in ophthalmology, which is called sympathetic ophthalmia. The second criteria, which we put in all criteria for diagnosis of uveitis, is exclusion of other diseases or similar diseases, and then we apply the diagnostic criteria. We have several types of VKH. We have complete VKH, incomplete, and probable VKH. And as I told you, Vogt-Koyanagi-Harada disease affects Beni-Uveitis, causes Beni-Uveitis. So it can cause anterior uveitis, intermediate uveitis, posterior uveitis, or Beni-Uveitis. I will show you some of the pictures that are familiar to us as ophthalmologists, but it may be helpful for you also. VKH, or Vogt-Koyanagi-Harada disease, causes granulomatous uveitis. As you can see here, this is the iris. And if you look carefully at the iris, there are multiple granulomas. And always when I see this, I feel happy, because presence of granulomatous uveitis narrow my differential diagnosis. When I have a patient in my clinic and asks me, wow, what is the cause of my uveitis? I tell him we have more than 150 causes of uveitis. When I see this granules, I narrow this 150 to even less than 10. So this is very important. I usually feel happy to have this granuloma, as I told you, because it narrows my differential diagnosis. It can also cause vitritis. As you can see here, this is a fundus image, but you can see the details of the optic disc and the blood vessels because of the presence of cells in the vitreous cavity. It can cause multifocal choroiditis. As you can see here, this nice illustration. These are actual patients of mine. You can have here the multiple foci of choroiditis here. It can affect the periphery of the retina. These are, in fact, called Dahlen-Fox nodules, which are peripheral neomular lesions in patients with old-standing uveitis. As we can see here also, there is thinning of the retinal pigment epithelium, and the fundus is hypopigmented because of the loss of the melanocytes in the retinal pigment epithelium. Here also, the RPE clumping, collection of pigments in some areas and loss of pigments in the other areas. But just the last slide in the VKH, I would like just to highlight that sometimes the manifestations of the VKH are confused with other important diseases, especially increased intracranial hypertension, because patients with VKH sometimes present with severe headache, as I told you, because of the involvement of the melanocytes of the meninges, and sometimes they have a swollen optic nerve head. So even the internal medicine specialist, when he see a patient with headache and swollen optic nerve head, he will think of serious pathology like increased intracranial pressure or even intracranial tumor. And some of the patients, in fact, will have unnecessary investigations like lumbar puncture and MRI of the brain. And at the last, they came out to be having VKH or acute Vogt-Koyanagi-Harada disease. The second disease entity today associated with uveitis, and in fact, it is common in our region, and I have diagnosed several cases of sarcoidosis. As you all know, you may know sarcoidosis even better than me. Sarcoidosis is a multi-system inflammatory disease with formation of granulomas in different parts of the body. The ocular sarcoidosis, about 30 to 60% of patients with sarcoidosis develop ocular changes. But here, uveitis is the most common presentation. So just this compares to the first three diseases we mentioned early in this lecture. Sarcoidosis, the most common affection here is uveitis. Again, the diagnosis of ocular sarcoidosis depends on presence of a compatible clinical picture, as we mentioned, exclusion of other diseases, but here also it depends on histological demonstration of granuloma. And you can see here, if you have a histopathological proof of biopsy showing non-caseating granuloma, this is the gold standard for the diagnosis of the disease. But pay attention, the biopsy in the eye is very hard and is not justified. It is not like the skin, or you can't take a biopsy from the choroid. You cannot take a biopsy from the optic nerve. So it is not usually possible to have a biopsy to diagnose ocular sarcoidosis. That's why the International Workshop on Ocular Sarcoidosis was held in Tokyo, in Japan, in 2006, in order to find the criteria to make a diagnosis of ocular sarcoidosis without invasive investigations. So can we achieve a diagnosis of ocular sarcoidosis without having to take biopsy? Yes. This group put 7 clinical signs suggestive of ocular sarcoidosis, and we are, as ophthalmologists, are familiar with these. They include granulomas in different parts of the eye. They include maton fat granulomatous keratic precipitates, trabecular meshwork nodules, snowballs in the vitreous, multiple chorioretinal peripheral lesions, nodular or segmental phlebitis, optic disc nodules or granulomas, and the bilateral disease. So 7 clinical manifestations we mentioned now, and 5 laboratory tests, which include negative tuberculin skin test or quantiferon, elevated serum ACE or serum lysosine, chest X-ray showing a bilateral hilar lymphadenopathy, abnormal liver enzymes, and CT chest if the chest X-ray is negative. And based on this, they put 4 levels of certainty to diagnose ocular sarcoidosis. The first level is definite ocular sarcoidosis. If you have a biopsy-supported diagnosis with a compatible clinical picture, and then you have a presumed, probable, and possible, and these with different combinations of the signs and investigations that we mentioned earlier. And these are the manifestations we see. These are the granulomatous KPs. Also, I'm very happy when I see this granulomas. These are the granulomatous or large maton fat keratic precipitates because they also narrow my differential diagnosis. These are the trabecular meshwork nodules, which are nodules at the angle of the anterior chamber. I'm sorry, I know most of our rheumatology colleagues are not familiar with this, but I just show you what we mean by trabecular meshwork nodules. These are the snow pools that we can see in the vitreous in the cases of granulomatous inflammation. These are multiple chorioretinal lesions. These are the philippitis, which is very important. The vasculitis here and the sarcoidosis is philippitis with the characteristic candle wax dripping, and optic disc granuloma also, which is presence of granuloma at the optic disc, is one of the manifestations that we look at when we are dealing with patients suspected of having sarcoidosis and bilateral disease. The investigations, I will just go to the details of the investigations that I have mentioned. Chest X-ray. In fact, I ordered chest X-ray for all my patients of uveitis. This is very important, and we have a rationale for this. The first, it is relatively cheap, and it can give us an information about two important diseases, which are TB and sarcoidosis, and they are great mimickers. In terms of TB tuberculosis, I need to exclude it as a cause of uveitis, and I need to exclude it also when I'm going to give the patient heavy immunosuppression or if I'm going to prescribe a biologic therapy. Interestingly, bilateral hilar lymphadenopathy can occur in up to 90% of patients of systemic sarcoidosis. So this estimates the value of this very simple test, which is a chest X-ray. Tuberculin skin test, a negative test, is mandatory to diagnose sarcoidosis because it is very unlikely to have a patient with positive tuberculin test and to diagnose sarcoidosis. And this can be explained by the sarcoidosis affect the T lymphocytes, and the BBD test or the tuberculin test depends on the T lymphocytes. It is a delayed hypersensitivity reaction. You inject the patient and you read the test after 2 days. And this depends on sensitized T lymphocytes. In sarcoidosis, these lymphocytes are not active. So you are not expecting a positive BBD, even if the patient has tuberculin. So presence of negative BBD test is mandatory to diagnose sarcoidosis. Elevated serum ACE. Also, serum ACE is very nice and the important test, but keep in mind some limitations. It is only positive in 60% of patients with sarcoidosis. So the presence of negative ACE doesn't rule out sarcoidosis. There are two important situations also I keep in my mind. When I'm ordering ACE in the children, it is normally high in the children. And in older population that are taking ACE inhibitors to control their blood pressure, sometimes their ACE is lower than what is expected because they are taking this medication. So when you interpret ACE, please keep these points in your mind. Abnormal liver enzymes also are put in the diagnostic criteria because sarcoid affects the liver. The last thing is CT of the chest, because sometimes I have a patient I'm suspecting clinically strongly sarcoidosis, but the chest X-ray is negative. So in this case, I'm justified to order high-resolution CT scan in order to look for bilateral hilar lymphadenopathy. Again, to summarize, we have 7 clinical signs, we have 5 clinical laboratory tests, and we have a combination of this, and it gives me honor and the privilege to be part of this prestigious group that recently put the recommendations for the management of ocular sarcoidosis. Sarcoidosis, again, can affect the other parts of the eye. We were talking about uveitis, as you can see here, but sarcoid can affect the eyelids, causing the nodules, can affect the lacrimal glands, causing swelling, can affect the sclera, causing scleritis, can affect the conjunctiva, causing conjunctival granuloma, and sometimes affect the extraocular muscles, as you can see here, and causing proptosis and can affect the orbit, again, causing orbital granuloma and proptosis and restriction of the movement of the eye. The next disease, which is common also in our region, is Behçet's disease. Behçet's disease, and also I'm sure you are more experienced than me with this disease, is a chronic relapsing occlusive vasculitis affecting almost every organ system in the body. It is common among what is called the traditional Silk Road. It is common in our region, and one of the highest areas of prevalence in the world. It includes Turkey and Japan, and in fact, most of the studies about Behçet's disease come from Turkey and Japan. In Egypt, we don't have so much studies, but the estimated prevalence of Behçet's disease is 3.6 per 100,000 population. It affects men more in the world, and in Egypt also it affects men more. And the mean age of onset is 25 to 35 years. And the pathogenesis is a little bit complicated, but finally it involves TNF-alpha and other cytokines. That's why we use biologic therapy in the treatment, and we use anti-TNF-alpha with magic results in the treatment of Behçet's disease. Again, the diagnosis of Behçet's disease, we don't have a diagnostic test. We are very unfortunate, like the VKH we mentioned before, like the sarcoidosis. Despite Behçet's disease was recently described, but we have more than 16 sets of diagnosis. I will show you 3 of them. One of the earliest diagnostic criteria included the Behçet's Disease Research Committee of Japan. And as I told you, Japan, one of the countries in which Behçet's disease is common. And they put major criteria and minor criteria. And I think these 4 major criteria are present in all classification systems, as I will show you. These include oral ulcers, genital ulcers, skin lesions, and ocular manifestations. And this, you will see now, these will be present in all classification criteria. So remember again, oral ulcers, eye manifestations, genital ulcers, skin lesions, and in addition to minor criteria like arthritis and others. And also they put different levels of diagnosis like complete, incomplete, and others. The second, which I think is one of the simplest, and the one is used in most of the studies in the literature and was used for several years, which is the system that was put by the International Study Group for Behçet's disease. And in order to diagnose Behçet's, the patient must have recurrent oral ulceration. So I think in this system, you can't diagnose Behçet's without presence of oral ulceration. So by applying this system, the patient must have recurrent oral ulceration in addition to 2 of the other 3 that we mentioned, which are genital ulcers, skin lesions, eye lesions, and we put here the pathology test, which is actually not done, I think. One of the recent classifications are the international criteria for Behçet's disease that was put in 2006. And you can see here also the first 4 are the same 4: oral ulcers, genital ulcers, skin manifestations, and ocular manifestations. But here, compared to the previous one, they put less stress on oral aphthosis or oral ulcers. Here, the one underlined, the genital ulcers and ocular manifestations, receive 2 points, and the others receive 1 point. If the patient has 3 points or more, you can diagnose him as having Behçet's disease. So here, you can diagnose patient with Behçet's without having oral ulcers. But in the more recent criteria that was put in 2010, they give the oral ulcers a similar strength to genital ulcers and ocular manifestations, giving each one of these 2 points and the others 1 point. And again, in order to classify the patient as having Behçet's disease, he should have 3 points or more. And these are some of the images in my patients. Oral ulcers can affect the tongue, as you can see here, or the buccal mucosa. Skin lesions can appear in the face, in the shoulders, in the hands. The ocular involvement in Behçet's disease, also uveitis, is very common and the most common presentation and can occur in up to 90% of patients with Behçet's disease. We have several forms of uveitis, but anterior uveitis is one of the most common. As you can see here, the patients on the right, they have anterior uveitis with hypopyon, and if neglected and not treated properly, it can cause complications in the anterior segment like cyclitic membranes, peripheral anterior synechia, and posterior synechia. There are some other anterior segment manifestations other than uveitis, like episcleritis and scleritis. And in fact, I have one of my patients, she's a female patient with a severe form of systemic disease, but her eyes showed only scleritis and not uveitis. The posterior segment affection in Behçet's is much more dangerous, and it is seen in 93% of patients. It can occur in the form of vitritis, retinitis, retinal perivasculitis, and macular edema. So this is vitritis. You imagine, how can this patient see? This is his vitreous. Vitreous is very cloudy, so this affects his vision. This is the snow pools, which are peripheral collection of white blood cells. This is macular edema. This is the image that we don't like to see, which is retinal vasculitis and hemorrhage and retinitis. And this is the more advanced retinal vasculitis. You can see here the sheathing of blood vessels, and the optic disc is starting to become pale. And this is the end stage, unfortunately, and we see this in several patients. Here he has severe vasculitis with ghost vessels and optic atrophy and the pallor of the optic nerve head. And these patients are blind, unfortunately. Thank you so much for keeping attention and listening to this heavy ophthalmology lecture. Thank you so much.
ربنا يبارك في حضرتك يا دكتورنا، ومحاضرة شيقة مش تقيلة ولا حاجة. يا رب يبارك. حضرتك سامعني؟
انا سامع حضرتك، انا متشكر
تمام،
جدا، تحت
تسلم.
امر
يا رب
حضرتك.
يكرمك.
انا جاهز للاسئله دكتور
ربنا
احمد، تحت
يكرم
امرك
حضرتك.
ان شاء الله.
طيب تمام، ربنا يبارك في حضرتك. وهو أول أسئلة كل الناس بتشكر يعني في حضرتك يعني.
الله
الحمد
يخليك،
لله،
تحت
الله
امر
يكرمك.
حضرتك، ربنا يخليك.
دكتور
اتفضل.
جزاك الله خيرا على المحاضرة القيمة. بعد إذن
جزاك الله.
حضرتك كان ليا بس كام سؤال.
اتفضل يا بيه.
دلوقتي يا دكتور، حضرتك في الحالة الأولانية حضرتك اللي هي كانت فيري سيفير كيس، كان معاها سكلرايتس و كورنيال انفلاميشن كيراتايتس. حضرتك استخدمت البروفيا، ايه الرول بتاعها؟
بص حضرتك، هو الحقيقه ده البيشنت كانت بتاخد التريتمنت ده. حتى انا قلت من الاول هي كانت بتاخد التريتمنت قبل ما تجيلنا. هي حتى كانت بتاخد الانفليكسيماب بريجيمن غريبه شويه. بس انا طبعا دوكيومنتد التريتمنتس اللي هي كانت بتاخده. احنا بالنسبه لنا ات هاز نو رول. احنا اللي احنا بنستخدمه اللي هو الهيفي اميونو سبريشن، سيستميك وتوبيكال. احنا ما بنستخدمش الادويه دي. اللي احنا بنستخدمه our regimen is to start with oral steroids and the conventional immunosuppressive therapy, and if they are not effective we shift to biologic therapy. بنستخدم التوبيكال ميديكيشن، التوبيكال steroids for a short period, and then we can revert to topical non-steroidal زي التكروليماس. لكن احنا مش احنا اللي اعطيناها العلاج ده، هي كانت جايه لنا وهي اوريدي بتاخد العلاج ده. وانا كنت قلت لحضرتك ان هي she was admitted and received this treatment. احيانا بيقولوا انه الدراكس اللي زي دي لها انتي كولاجينيز اكتيفيتي. فاهمني حضرتك؟ يعني في بعض الناس بتديها لانها لها انتي كولاجينيز، والكولاجينيز هو اللي بيبقى مسؤول عن الكورنيال ميلتنج. فانا لما بقلل الكولاجينيز اكتيفيتي بقلل الكورنيال ميلتنج والبرفوريشن واللايكليهود اوف برفوريشن.
طيب يا دكتور، في سؤال. when we give pulse steroid in case of uveitis، يعني احنا عندنا دايما في الروماتولوجي البلس ده في الحالات الاورجان ثريتنينج او اللايف ثريتنينج. فايه الحاجات الفيجن ثريتنينج اللي لما نشوفها ممكن نبدا اجريسيف؟
جميل قوي. بص حضرتك، هو برضو ده سؤال جميل جدا الحقيقه. احنا بندي في الحالات بقى سايت ثريتنينج مش لايف ثريتنينج. بالنسبه لنا السايت هو اللايف طبعا. بتكلم حضرتك ان جنرالي ان براكتس اكتر حاجه احنا بنعملها في حالات الاكتف او الاكيوت Vogt-Koyanagi-Harada disease. الحالات دي بتبقى presenting with severe acute exudative retinal detachment، ودول بيستجيبوا دراماتيكالي للبالس ستيرويدز لانه بيبقى عندهم سيفير فورم اوف كرويدايتس. وبالمناسبه ما بيبقاش معاهم يوفيايتس اكتف، يعني ما بيبقاش معاهم سيلز يعني او فلير في الانتيريور سيجمنت ولا في الفيترس، لكن بيبقى معاهم كرويدايتس ما بتبقاش باينه، ولكن they respond dramatically للستيرويدز. دي حاجه بنديهم
تمام.
بالس ستيرويدز وبعد كده بنديهم على الاورال. تاني حاجه حالات البهشس ديزيز اللي معاها سيفير ريتينال فاسكولايتس وبريزنت ليتلي، دول بنديهم بالس ستيرويد ثيرابي تو بروتكت ذا اوبتيك نيرف هيد، لانه دول لو احنا ما عالجناهمش بسرعه بيحصل لهم اوبتيك ديسك فاسكولايتس وممكن تو لوز فيجن كويكلي. دول اكتر الحالات اللي احنا بنديهم الحقيقه بالس ستيرويد ثيرابي لما يعني جنرالي لما يكون في حاجه سايد ثريتنينج.
طب هل البانيوفيتس انديكيشن، يعني مثلا ساركويد جاي بايلاترال بانيوفيتس او بيهست، يعني قصدي مش ديزيز سبيسيفيك بس كبرزنتيشن؟
لا، البانيوفياتس لوحدها is not an indication of pulse steroids، لانه ممكن تكون mild بانيوفياتس حتى لو هي severe بانيوفياتس، بس انا ما عنديش damage للاوبتيك نيرف او threatening damage للاوبتيك نيرف او البلاد vessels. They respond dramatically to oral steroids and combination with immunosuppressive therapy. So إجابة حضرتك تحديدا لو بانيوفياتس مش indication أبدا للبلس ستيرويد.
طيب تمام يا فندم. طيب كان سؤال على الكلوروكين او هيدروكسي كلوروكين في السايد افكت. What about monitoring of hydroxychloroquine in risky patients؟
ممتاز
يعني
برضو.
الريجيمين كل قد ايه، ولازم بيز لاين ولا لا، وفولو اب؟
ممتاز سؤال جميل جدا يا دكتور احمد. بص حضرتك، هو according to the American Academy of Ophthalmology guidelines كل المرضى لازم نعمل لهم baseline examination. يعني حضرتك اذا قررت تدي العيان هيدروكسي كلوروكين يبقى هو محتاج بيزلاين اكزامينيشن. وده ليه راشونال، احنا زي ما قلنا ان في حاجات بتخلي المريض اكثر عرضة ان هو يحصل له توكسيسيتي زي البري اكزيستنج ماكيولار ديزيز، فحضرتك طبعا هتبقى مش شايفها. فحضرتك بتبعته لي خاصة مثلا لو هو دايابيتك أو أولد إيج، لأن هو ممكن يكون بالفعل عنده ماكيولار ديزيز، ففي الحالة دي هقول لحضرتك خلي بالك والأحسن إن إحنا نشوف ايجنت تاني. فالبيز لاين ده مطلوب لكل الحالات. بعد كده بنعمل annual assessment بعد 5 سنين لو هو ما عندوش ريسك. يعني حضرتك اول حاجه هنعمل بيس لاين لو هو بقى ما عندوش ريسك، يعني لو انا حضرتك شفته لقيته ما عندوش ماكيولر ليجن، ولو هي ليدي ما بتاخدش التاموكسيفين والكدني بتاعتها كويسه والدوز اقل من 5 مللي جرام بالكيلو جرام بير داي وبياخدوا اقل من 5 سنين، ده مش هاي ريسك، يبقى انا هشوفه بعد 5 سنين. لو كمل 5 سنين من العلاج ابتدي اشوفه كل سنه. لكن لو هو عنده الريسك دول ببتدي اشوفه انيولي على طول.
تمام يا دكتور.
واضحه كده دكتور احمد؟
اه واضحه خالص. طب في
تمام.
سؤال، هل الكورنيال ديبوزيت ده يخليني اوقف هيدروكسي كلوروكين، او ايه الانديكيشنز اللي اوقف عليها
لا
هيدروكسي
لا لا
كلوروكين؟
اطلاقا، بالعكس بالعكس، لا خالص، لا خالص، اطلاقا لا خالص. بس هي يعني احنا برضو لما احنا نشوفها نراجع بقى الريسك فاكتورز بتاعتنا. يعني احنا لو شفنا الديبوزيتس دي ابتدي انا اشوف هل هو بياخد 400 مللي جرام في اليوم مثلا وبقى له قد ايه، لكن هي مش انديكيشن تو ستوب ذا ميديكيشن، بس هي بتالرت يو ان هو there are some changes لكن it's not an indication to stop.
طيب في سؤال بقى معلش يا دكتور، عن بي 27 اسوشيتد يوفيايتس. لو اتش ال بي 27 ايزوليتد اكيوت انتيريور يوفيايتس، معهاش جوينت ولا سباين او حاجه، هل هنبدا لها سيستميك تريتمنت ولا هي كانتيريور هنعالجها توبيكال؟
ممتاز، برضه سؤال جميل جدا وده ان براكتس. احنا طبعا عندنا في حاجه اسمها بي 27 associated uveitis وفي بي 27 related uveitis. اللي حضرتك بتسال عليه ده بي 27 related uveitis اللي هو ما عندوش ankylosing spondylitis ولا الاذر سبوندايل ارثروباسيس، ولكن هو عنده بي 27 بوزيتيف وعنده uveitis لها نفس البيهيفير بتاع البي 27 associated. ودي عادة بتبقى يونيلاترال. هنا الجادج بتاعنا او الجايدنج بتاعنا هو الكلينيكال ريسبونس. يعني بص حضرتك، لو هي حالة يونيلاترال ومايلد او مودريت او ايفن سيفير لازم ببتدي معاها بالتوبيكال ثيرابي الاول وحسب الريسبونس بتاع الثيرابي. لو ببتدي بالتوبيكال ثيرابي اللي هو التوبيكال اي دروبس، وباخد العلاج فيري انتنسيف لمده 4 ل 6 اسابيع. لو البيشنت ريسبوندنج ما بعملوش اي حاجه تاني وبراقبه. لو حصل ريكورنس بعالجه بنفس الطريقه، او استيب اب ان انا اديله ريجونال ستيرويد اذا استدعى الموضوع. لكن اذا لقينا الاتاكس بتبقى ريكورنت وانس ان انا بستوب التوبيكال ميديكيشن، يبقى ده هو الانديكيشن ان انا اخد سيستميك ثيرابي. يبقى انا لازم اعرف احاول بالتوبيكال ثيرابي الاول اكونترول البيشنت. لو التوبيكال ثيرابي فيلد او عمل سايد افكتس زي الجلوكوما او الكاتاراكت، ساعتها لازم ادي steroids with or without conventional immunosuppressive therapy.
طب حد بيسأل الديفرنس بين سنترال كيراتايتس وبريفرال كيراتايتس؟
جميل. برضو سؤال هايل خالص، وله علاقة جدا برضو بموضوعنا النهاردة. السنترال كيراتايتس موستلي ما بتحصلش مع الروماتولوجيك ديزيزز. ليه؟ لأن احنا لنا علاقة بالبلاد، والكورنيا إذا فاسكولار. الكورنيا فاسكولارايزد من البريفري بس، فاحنا بيجي لنا الانتي بوديز على البريفري. تمام. فانا لما بشوف سنترال كيراتايتس او كورنيال ألسر سنترال بفكر في انفكشن، اما بتبقى بريفرال بفكر في اميون ميديتد ديزيز اكتر. which makes sense. انا عندي الانتي بوديز بتيجي من البلاد، والبلاد اخره على الليمبس ما بيوصلش للكورنيا، والحمد لله ربنا خلق لنا الكورنيا ايفاسكولار عشان نعرف نشوف. لو فيها بلاد فيسلز مش هنشوف. فبالتالي لما يبقى عندي سنترال كيراتايتس او سنترال كورنيال ألسر، it is very unlikely to be associated with a rheumatologic disease لان انا ما عنديش انتي بوديز في السنتر اوف ذا كورنيا.
تمام، ربنا يكرمك يا دكتور. معلش في سؤال برضو، لما ابدا اميونو سبريشن في حاله هراده او بيهست، احتاج ان الفولو اب بعد قد ايه، واتوقع تحسن بعد قد ايه، واعمل تيبرنج للتريتمنت بعد قد ايه؟
ممتاز. هو بص حاجه برضو، ده برضو حاجه كويسه جدا لازم برضو ننبه ليها زمايلنا خاصه الاوفثالمولوجيست. احيانا يعني بيصعبوا مشكله او بيصعبوا مهمه الروماتولوجيست، انه في احيانا بعض الزملاء بيكتب في الريفيرال ليتر بيقول من فضلك انا بعت لحضرتك حاله فوجت-كويناجي-هارادا ديزيز، او سوري حاله بانيوفيايتس فور يور كايند كير. دي مش الطريقه الصحيحه. الطريقه الصحيحه ان انا بكتب تشخيص وموست لايكلي دايجنوزس، وبسبورت كمان الايه الريجيمن، لانه حضرتك كروماتولوجيست مش هتقدر تؤسس الاكتيفيتي ده. برضو اجابه سؤال حضرتك. لكن انا بالنسبه لي ايه اللي انا بعمله عشان هكتب بقى وير، ان انا ببتدي بالستيرويدز الاول. باي ذا واي احنا برضو في الاوفثالمولوجي ويعني اي ماي سيلف دونت جو مور ذان 40 ملي جرامز بير داي. كويس. وعلى حسب تقييمي انا وماي اكسبيرينس، لو انا شايف الحاله سيفير ببتدي معاها كونفشنال اميونوسبريسيف ثيرابي على طول، زي الميثوتريكسيت مثلا. وانا عارف طبعا الميثوتريكسيت بياخد اب تو 4 to 6 ويكس ان هو يشتغل، فبعمل كفرنج بالستيرويدز للفتره دي حسب السيفيريتي. يعني most of the cases في الاول انا بكيب watching the patient very closely، بس عاده بشوفه بعد اسبوعين من بدايه العلاج. لو لقيت الانفلاميشن بيقل وانا بقدر ادجدج ده من خلال مواصفات معينه انا بشوفها، زي مثلا الكيراتيك بريسيبيتيتس لو هي subsided، بعمل جريدنج للانتيريور تشامبر سيلز اند فلير بالاكزامينيشن، بعمل جريدنج للفيتريال سيلز، وبعمل كومبليت ريكوردنج الحالات دي. لو لقيت البارامترز دي بتقل ببتدي افكر في ان انا اتيبر التريتمنت. فكره ان انا افضل اعالجه لحد امتى برضو ده يعني سؤال للاسف ملوش جولد انسر او
ايوه. ده الموبايل معلش.
لا لا اتس اوكي اتس اوكي. انا بس مش عايز اطول على حضراتكم، لكن هي الفكره بتعتمد على الكلينيكال جادجمنت. انا بشوفه بعد اسبوعين. انا شخصيا بشوف المريض بعد اسبوعين. ممكن اشوفه طبعا في وقت اقل لو هو عنده سيفير يوفيايتس مثلا، او عنده حاجه سويت ثريتنينج زي الاوبتيك نيرف افكشن او ريتينال فاسكولايتس.
طيب معلش احنا تعبنا حضرتك والاسئله كتير على الشات، بس
بالعكس.
مش عايز اثقل على
لا
حضرتك.
لا لا خالص، انا مع حضرتك تماما تحت امرك في ايه. اتفضل.
طيب ماشي يا فندم. هو في سؤال، لو بهشت ورابidly diminished visual acuity بس without overt anterior or posterior uveitis, do we wait overt uveitis to start biologic, or should we start preemptive treatment in the setting of visual acuity loss؟
تمام. برضو سؤال جميل وبراكتيكال جدا. احنا من الحالات اللي احنا we are justified to start biologic therapy from the start هي حالات السيفير acute Behçet's، والحالات اللي هي الجي اي اي juvenile idiopathic arthritis. هو كل الريكومنديشنز ان احنا بنبتدي بالكونفنشنال ثيرابي الاول، واف فيلد بنروح على البيولوجيك ثيرابي زي الروماتولوجي. لكن في حالات السيفير يوفيايتس ومن ضمنها البهشت ديزيز ريتينال فاسكولايتس we are justified to start with biologic therapy، لانه البيولوجيك ثيرابي بيجيب نتائج كويسه جدا جدا في الحالات دي.
تمام. احنا هاخد سؤالين وخلاص بقى في المحرك عشان ما ننتقلش على حضرتك تاني. حد من زملاء بيسأل هل بوستيريور فيايتس الاوفثالمولوجيست يشخصه بس كلينيكالي ولا لازم او سي تي؟
تمام، جميل خالص. بص حضرتك برضو يعني سؤال يعني برضو فيه تريكس. البوستيريو فياتس از موستلي از ا كلينيكال diagnosis. لان يعني ايه بوستيريو فياتس سيمبلي؟ يعني البوستيريور بارت اوف ذا يوفيال تيشوز افكت، اللي هو ايه في كلمتين، يا اما كورويدايتس يا اما ريتينايتس او الاثنين، ريتينوكرويدايتس او كوريوتينايتس، وده كلينيكال diagnosis. دي حاجه بقى اوفثالمولوجي. دي الاو سي تي بيشخص ماكيولر ايديما. لو حضرتك هتعمل ماكيولا، هي ماكيولر ايديما، بس وجود الماكيولر ايديما ما يعنيش بوستيريور يوفيايتس خالص. الماكيولر ايديما it is a complication of uveitis، ممكن تحصل مع السيفير انتيريور يوفيايتس. حضرتك ممكن يبقى عندك حاله بي 27 يوفيايتس انتيريور بس ويحصل معاه ماكيولر اديما، فوجود الماكيولر اديما ما بيشخصش بوستيريور فيايتس. دي حاجه. الحاجه الثانيه ممكن الاو سي تي يساعدنا تو كاركترايز ذا ليجن. لو انا عندي مثلا حته فيها انفلتريت، ممكن الاو سي تي يقول لي اذا كانت في الكرويد ولا في الريتنا، وده بيساعدني ان انا اعرف هي كرويدايتس ولا ريتينايتس.
تمام يا فندم. اخر سؤال بقى عشان وقت حضرتك. حاله بانيوفيايتس وريتينال ديتاتشمنت والام ار اي برين مطلع باتشي كورتيكال ليجن كويري ديمايلينيتنج، فبيسأل حضرتك من وجهه نظر الاوفثالمولوجي ايه اللي ممكن مثلا يكون في الديفرنشال معانا؟
طيب بص حضرتك، هو حضرتك ال كده احنا بنفكر في ام اس. لو في عندي باتشز اوف ديمايلينيشن يبقى انا بفكر في الام اس. بس الام اس المالتيبل سكليروزس ما بيعملش بانيوفيايتس. اكتر حاجه بتحصل مع الام اس هي الانترميديت يوفيايتس والسبيل اوفر انتيريور جرانيلوماتوس يوفيايتس. واحنا شخصنا كاوفثالمولوجيست حالات كتير ام اس. بناء على كده انا لما بشوف حاله بانيوفيايتس ما بحطش في الديفرنشال بتاعي ام اس وما بطلبش ام ار اي اوف ذا برين. انا بطلبه لما بلاقي intermediate uveitis، خاصه في فيميل ميدل ايج فيميل بيشنت ومعاها سنو بولز او معاها anterior granulomatous uveitis. دول بعمل لهم ام ار اي اوف ذا برين، يطلع ام اس او ما يطلعش. لكن الحقيقه عشان الاقي باني اوفيايتس وريتينال ديتاتشمنت وكورتيكال باتشز مع بعض، دول يعني it doesn't make anything in my mind. الباني اوفيايتس مع ريتينال ديتاتشمنت لوحدهم دول يخلوني افكر في كي اتش. لو معاها بقى باتشز، لو دي حالة حقيقية حضرتك شفتها ومعاها باتشز، يبقى ده ممكن يكون كو انسيدنت اوف ام اس مع اليوفيايتس.
هي دي مش حالتي، ده حد من الزملاء بيسأل. طب
اه ما انا فاهم
احنا
حضرتك. هو
متعودين
لا.
البانيوفيتس لو مثلا وسي ان اس ليجنز طبعا من غير الريتنال ديتاتش حضرتك تقول يعني النيورو بيشت او الساركويدوزس ممكن يعملوا سي ان اس وبانيوفيتس، بس هل
تمام
الريتنال
اه.
ديتاتشمنت وارده مع الاثنين دول؟ ممكن
مع الايه يا فندم؟
مع البيست والساركويد هما الاثنين
لا
ممكن يعملوا
لا
بان ويعملوا سي ان
اه
اس ليجنز.
ممكن بس ما بيعملوش ريتينال ديتاتشمنت.
اه
يعني الساركويد ما بيعملش ريتينال ديتاتشمنت، والبهشت ريرلي يعمل بهشت يعمل ريتينال ديتاتشمنت في الاول. ممكن يعمل لاسباب تانية، لو هو لونج ستاندنج وعمل ماكيولار هول فور اكزامبل، او نتيجه الانترافيتريال انجكشن، او نتيجه البريفرال ريتينال اتروفي، وده بيبقى في عين واحده. لكن اللي بيعمل بانيوفيايتس مع ريتينال ديتاتشمنت اكيوت ريتينال ديتاتشمنت هو الفي كي اتش.
تمام يا دكتور، ربنا يبارك في حضرتك، تعبنا حضرتك.
اطلاقا والله، بالعكس بالعكس.
وممكن ان شاء الله نطمع في محاضره تاني فيها اسئله
طبعا
كتيره عن
طبعا
الاو سي بي الاوكلر سكاتريشن بالفيجويد
ان شاء الله.
والمايمكس الانفكشنز والحاجات دي. فدي برضو عشان اوت اوف سكوب اوف ذا ليكتشر، فبرضو ممكن بقى نتشرف بحضرتك في مره
ان
تانيه
شاء الله يا
او.
دكتور احمد، انا سعدت جدا بوجودي مع حضرتك ومع
واحنا بصراحه ممتنين جدا لحضرتك بصراحه. تاكل
ربنا.
ذا توبيك فيري ديفيكالت ويمكن بنواجهه كتير، وحضرتك بسطته لنا خالص كروماتولوجيست يعني. بنشكر حضرتك جدا جدا
ربنا
جدا.
يخليك دكتور احمد، تحت امرك دايما.
والف الف شكر لحضرتك يا فندم.
شكرا لحضرتك، شكرا جزيلا.
وبعتذر للزملاء اللي باعتين اسئله، والله الاسئله كتيره بس هو عشان وقت الدكتور يعني. وان شاء الله هبعتها للدكتور وممكن في محاضره ثانيه ان شاء الله.
ان شاء الله تحت
شكرا
امر
يا فندم،
حضرتك.
شكرا يا فندم.
مع
مع
السلامه، مع
السلامه، مع
السلامه.
السلامه.